Okay, so welcome everyone to the Improving Population Health theme. This seems like it's really loud, or is that just my imagination? I feel we should be engaging in some gym activities, really, but I'm just going to practice my car wheels. So today, as part of the Improving Population Health theme, we're going to be talking about how, as a sort of health and social care system, we could, and as an ARC, how we could support improving the support for families with complex needs. I'm just going to talk a little bit about this project that we have called System P, which is aiming to support the integrated care system in doing that. And then we'll hear some from each of the panel who have expertise and experience of how that system works and how it might be improved and how we could potentially use this work to improve it. So first off, I'm Ben Barr. I'm Professor in Public Health at the University of Liverpool, and I lead the Improving Population Health theme. And I'll just ask each of the panelists to introduce themselves, starting with you, Michael.
Yeah. Hello, everyone. My name's Michael Galbraith. I'm a clinical psychologist and systemic psychotherapist, and I work in the parent-baby relationship service, which is part of PSS, a third sector organisation.
My name's Bryony Kendall. I'm a GP with the lead for safeguarding, and I've been involved in the NIHR and Health Foundation project of Ways to Wellness in Liverpool, but I also sit on the Maternity Disparities Task Force for the government.
Great.
Hi, my name's Colin Doyle. I am lead midwife for a new service called the Silver Birch Maternal Mental Health Service that supports women, birthing people who have suffered trauma and perinatal loss through a maternity or neonatal journey. But previously, I was team leader for a vulnerable families midwifery team and also a non-English speaking team. So I manage that within Liverpool Women's Hospital.
Hi, I'm Jo Hunt. I'm the lead midwife for health inequalities for Cheshire and Merseyside LMS at the local maternity system. So I'm working on various projects at the moment, including the smoking and pregnancy project. And prior to that, I was a continuity of care midwife in the first team to be launched, which was really successful and has been replicated up and down the country now, and was a background as a homeless officer and working with teenage mums, etc. prior to that.
Brilliant.
I'll actually have the mic there. So my name's Paul Moran. I'm one of the public advisors and co-theme leads for the HCAL theme. I'm a coach at Ultra One Boxing Club, so I work with kids from 6 years of age right into adulthood. And we're currently just setting up a program that you might have seen on a few things over the past couple of weeks, with its Weapons Down, Gloves Up campaign to try and capture, those kids that are falling through the gaps of our systems and pulling them into something which is really interesting and then improving their, prospects in life. So yeah, that's myself.
Great, thanks everyone. So we're doing some work as part of a project called System P. And this has been kind of commissioned by the integrated care system for Cheshire and Merseyside. And the whole idea of that project is to use some of the kind of linked data resources we've been hearing about earlier today to really understand what are the needs of different groups in the population, and to understand how we can better sort of redesign some of the services to improve outcomes for patients and the public. And so this work is across Cheshire and Merseyside, but with the particular focus on households with complex needs is within Liverpool. And the idea is, this is all part of what's called a sort of learning health and social care system, as if that we can better identify needs in the population, target services to address those needs, evaluate what works and what doesn't, and use that to inform how we kind of redesign services. And that should improve the outcomes for the people using them. So we have data across the whole population of Liverpool from all the different health and social care services that people use. So that could be from primary healthcare that we heard this morning, from the GP, from secondary healthcare, from the hospitals, mental health care services, community healthcare services, adult social care services, children's social care services, and also things that we might know about the environments that people live. As part of this project, one of the sort of new things that we have been able to do with that data is to understand households rather than just thinking about individuals. So looking at families and what are the needs and use of healthcare services across the whole family. And through the integrated care system, we have access to an anonymized kind of version of this, but we can, so we can't identify anyone from it, but we can use it to help analyze that, to help inform services, and we can tell which group of people live in the same household, so we can start looking at needs for the whole household rather than just for the individuals. So as part of that, we've identified a sort of group of 5,000 households. That's about, and here we've focused only on households that include children, because we're also particularly interested in the outcomes for children and how the needs of the whole household influence the outcomes for children. So we've got this 5,000 households, that's about 10% of all households with children in Liverpool. Altogether, they account for about 35% of all the health and social care spending on households with children in Liverpool. Just to give a picture of some of the needs, pretty well almost all of the households have mental health needs, that have at least one person with a mental health need. About 40% of the adults have a mental health need, and 20% of the children have a mental health or learning difficulty. For the adults, to a large extent, that's kind of depression is the biggest, depression and anxiety is the biggest issue. It's quite a relatively high number of people in those households with alcohol and substance misuse. Lots of the children, as we said, have health and social care needs, but in lots of those households, it's also the parents and the children both have health and social care needs. At the moment, there are lots of services all targeted to the different needs of the individuals in those households. I mean, we've heard in the earlier session, there's lots of services that are targeted to the individual diseases of the individuals within each household. So separate services for each disease and also separate services for each individual. There's very little that's really taking into account the whole complete needs of the household, as well as people with health and social care needs, but also their carers within those households. So this is just a breakdown of kind of their use of services, these 5,000 households. So the big things are using mental health and learning disability services, emergency secondary care use, so A&E and emergency admissions, and children's social care. And then there's a whole mass of different services and initiatives that are all fundamentally trying to target and support the same group of households to a large extent. That's all the sort of universal services like midwifery and health visiting, as well as sort of specific initiatives targeting particular groups. At the moment, we don't even know really what the overlap is between the use of those different services. So that's something that we can start to look at as part of this project. This is just some of the mapping of different services that we've been doing with Merseycare, looking at the mental health services for children and young people. Sort of 39 different services from 14 different providers, all costing about £25 million. So quite a sort of fragmented set of services, but also the kind of coordination and groups that are trying to coordinate those services are also quite fragmented. There's lots of different kind of groups and boards that are trying to coordinate those services. We worked out there are about 28 different governance groups across Cheshire and Merseyside, and even just the cost of the numbers of people attending meetings of those governance groups was pretty large when you started kind of adding up those figures. So not a quite a fragmented kind of governance arrangements, but also fragmented services. And this is just some of the sort of feedback from some of the work that the integrated care system has been doing with service users, basically highlighting how the services can often seem quite inflexible to the people that are using them. They sort of run often focused on sort of specific diagnoses rather than thinking of the family as a whole. So I will leave it there and hand over to my panel for their thoughts on how can, from where we are, what could be done to better support families with complex needs? How could things be improved? And in particular, is there something that we could do as an ARC as part of this work? And any ideas of how we can best do that to improve implementation of evidence that we already know about, but also evaluating what's currently going on. I'll start with Bryony.
Thank you. I think there's something about supporting these families. We probably know who they are, and there's too many disparate people involved, and there's a sort of lead professional model, but it's not always available, and often people kind of dip out of being that lead professional. So there's the time and capacity, opportunity, motivation to be the lead person to pull that all together, and each organisation probably thinks it ought to be somebody else, and it's very difficult to manage that. We could probably be better with signposting, and that in the broadest sense, so to commission services, whether those services are commissioned, so the capacity, access, integration of those services. For example, everyone being better at identifying whether adults need their own social workers, whether they have care and support needs themselves, and whether those two aspects of social care talk to each other with the different healthcare people involved. I think there's such a lot going on here. And I think I want some critical notices as well. So there's the people that we expect to be involved. So, for example, children's social workers, primary care. And I just want to be a little bit careful about the usage of the word primary care, because it's not exactly synonymous with general practice. Primary care involves optometry, dentistry and pharmacy, all of which I would love to be involved as well. I want this to be a system approach. Are these families approaching pharmacies? Are they accessing other ways of accessing health needs? Because it's very difficult to get, for example, a face-to-face appointment with a GP. So the whole broad system, and putting it all together is going to be tough. But I think we need to take a step back, and if we can identify these families, I think at an ICS level, this is a huge opportunity for an ICS, but at a place with a lovely strategic, consistent approach to how we identify this, but with the local needs. And just go back to critical notices. So people like the police, for example, so if they're attending a domestic abuse situation, they would say, well, we do our bit. We're not expected to pick up the health and social care needs, but we will signpost in. Lastly, I'm absolutely thrilled to be working in Liverpool, where social prescribing has an anti-poverty focus, because that's absolutely crucial. And we recognise that's not the case around the country, but that's so useful here. And I'd also want social prescribing with legal literacy, because I think access to justice is a public health issue, and I think these families may have actual legal needs, and I think unless we're cited on that and recognising the immense amount of legal literacy needed to survive is an aspect there.
Yeah, some really important points there. Just maybe a couple of things for clarification. Critical notices, what did you mean by that? So
a critical noticer is someone who, so for example, the police, I just want them to have a little spark when they, attend an event or they have contact with these families, which I think we would agree they do. And preventative policing is increasingly recognised as a core thing. The Merseyside Fire and Rescue Service is doing more and more preventative stuff. And these are people, we don't necessarily want them to do the health and social care things. I just want them to just go, okay, you're a critical noticer, you plonk in. Anyone within primary care, across these pharmacists, optometrists, dentistry, we talked earlier about the importance of oral care across the life course. If you're seeing someone, just think, are you part of this? Can I just send you in a little bit, sort of early help across the entire live course? But to have a whole ownership, whatever your professional background, you are just seeing this and going, I recognise there's an issue here. It's not something that is my profession to deal with, but I'm just going to pass it over and just sort of signpost the person the right way. And signposting rather than sort of abdicating full responsibility and saying back to you, but sort of saying, do you know what? I think there are support services available locally that can help you, and this is the kind of these are the people who to tap into.
Okay, great. I think there's lots of things around the practicalities of how we can organise that, which I think would be really useful things that we can start to think about. To go to Paul, do you want to give your...
Yes, I think probably my comment would be, obviously we work with lots of young people. The young people don't know they've got complex needs, and so they just know they are a person who, you know, is maybe a little bit different from the people that they see all day, every day. We as coaches have got to kind of pull out what are their additional needs, you know, within that session, and how can we help and support them to kind of create opportunities, especially the younger people. You know, the amount of parents that come in and say ADHD, Asperger's, whatever else, I don't understand, and the kid definitely doesn't understand. We've just got to kind of build that relationship with that child to really kind of focus on what their needs are. I think as you go on into the older age group, sometimes people think that those kids are already lost. So, you know, if you go into 15, 16, 17, 18-year-olds, are they too old for child services? Are they too young for, you know, adult social care services, especially in terms of mental health? And that's why we try and kind of, you know, signpost kids of that age into creating positive opportunities for them. So not concentrating on what's going wrong in their life, but concentrating on what the strengths are and what could go right in their life. Hence the kind of the Weapons Down, Blows Up campaign, where we're trying to get kids who are just falling through the gaps with no real prospects in life, using boxing as a hook to get them into the gym, and then kind of, you know, doing some sessions with them to then take them into the classroom, build their life experience, do things like CV writing and interview skills, and then getting them a job at the end of it. And then as soon as they get that job, they've got a life to then, you know, pursue them. But, you know, I've said upstairs, I'm an uneducated person. I'm not an academic by any means. And, you know, we talk about social prescribing a lot, especially in kind of, you know, the HCAL thing where we're working. Well, do you know what? There's hundreds of boxing clubs, there's hundreds of athletics clubs, there's hundreds of football clubs. How did we ever think about social prescribing in terms of a coach really knows a kid because they spend probably 10 hours a week with that kid? You know, I had never been asked to, you know, do anything wrong along those social prescribing. So how can we build into those networks to make the community more responsible for that child and not just the parents?
I think there's some really good things, and some of the I think one of the things that us as professionals are really terrible at is just using labels all the time to try and categorize groups of people, and that are often in themselves kind of limiting in, you know, and, you know, talking about complex needs or, you know, different sort of diagnoses that young people can end up with. You know, there's how we can reframe the whole language around talking about them is not about kind of deficits, I suppose, and needs. Even the word needs is potentially something that we need to move away from. And clearly the importance of that sort of transition, which everyone in the service knows is a big issue as well. But how we can reframe that in a way that goes beyond the sort of health and social care kind of model and brings in the kind of things that you're talking about. Great. So, Michael.
Okay, so as a family therapist, one of our ideas is that you can't understand systems by breaking them up into little bits, that the whole is greater than the sum of the parts. And that's a problem, I think, for the way that services are organised at the moment, because they break people up into separate bits, and then sometimes they break the person up into separate bits even further, which you were kind of referring to before. So the risk of kind of sounding unhelpful, to solve this problem, I wouldn't start where we're starting now. So, but, you know, I think there's an issue about commissioning. there have been examples kind of nationwide of, for instance, family mental health services. There was a family mental health service in Birmingham where people of all age could go. In fact, they could self-refer. And it worked with adults and children and adolescents on whatever they brought with the people that were kind of meaningful to them. So, for instance, dare I say it, the maternal mental health service, I think, is a kind of missed opportunity from a commissioning point of view, because as far as I understand, according to people yesterday, dads are excluded from that. And so again, we've set up a gendered kind of selective service. So, you know, just in terms of commissioning, thinking kind of family. In the service I work in, we say that the client is the relationship between the parent and the baby. It's not one or the other. It's the relationships between the two. And so I think that kind of approach would be good. If I've understood the graphs right, I don't think the third sector are on there at all. And I kind of guess that kind of picks up on the point before about actually community-based organisations, third sector, athletics, things, faith groups and so on, and actually kind of broadening our understanding of what supports health and well-being. And I go back to the Sure Start local programme that was statutory, but was multi-agency, multidisciplinary at a community-based level, and had 4 objectives in the Sure Start local programme. The first 3 were to do with supporting the child's physical development, social emotional development, and cognitive development. So physical, social, emotional, cognitive. And then the 4th objective was strengthening families and communities. And when I joined the Sure Start local programme, I thought, what the heck does that mean? And wasn't really clear about that. But I came to see that actually that was the most crucial one of all of them. And I would question whose objective it is at the moment to strengthen families and communities. And that's what I would put into this.
Yeah, really important points. And I guess one of the, there were some of those models and assets around Sure Start, for example, that, you know, by the time they were starting to get the picture were lost.
Yeah.
So, is how we actually have that sort of sustained issue. And I guess, and one of the other kind of challenges, I suppose, is how, how to have sort of open and inclusive services, but also when there's limited resources, how to manage the sort of demand for support versus what can be delivered. I suppose is another issue. Really good points. Okay, we'll move on to Carmel. And you can do a double act.
You can do a double. I'd just like to start, I think really, I don't want to be a negative in any way, but I believe as a midwife, we are really pivotal in change, really, about changing life, really. And I think we're in a really important opportunity as a midwife. For me, I think the problem is assessments, personally. I think assessments from lots of services, but particularly from social care, so I'm sorry any social workers are in the room. I think the pre-birth assessment for me is not fit for purpose. I think it's different in different boroughs. So in Liverpool, across Wirral, Liverpool, Knowsley, we've got different pre-birth assessments in each of the areas, even though we've got a pan borough to follow. They don't complete those pre-birth assessments until after a viable pregnancy, which is 24 weeks, 23 weeks and 6 days. However, other services work with families before that. So my question to social care is why not? Why don't those pre-birth assessments actually happen before that 23 weeks and 6 days? I think the other issue really is we've got really complex families who've not been assessed if they're neurodiverse. So we're finding an awful lot of women that come through maternity that have been, if they've been failed in education or that services haven't been included. So we're seeing the issues within the maternity setting where they're really struggling to even process some information which actually impacts them on that parent and infant mental health, impacts on their own mental health. For me, I think those women, when the practitioner actually needs to assess if it's by social care or if it's by a practitioner, that they need to be fast-tracked into an assessment when they're pregnant, because they've got the biggest chance of losing their babies to social care at that point. And I think that's where we need to look at that on a Cheshire and Merseyside and wide point of view. I think it needs to be joined up work. I think we haven't got enough social workers, obviously, but we haven't got enough in any service. So do we train other services to actually work in collaboration for pre-birth assessments? But I think there's a few issues there. There's one, that I don't think the assessments are fit for purpose. Two, I think we are actually in maternity having more women with really complex needs that are waiting 2 to 3 years for an assessment whether they are neurodiverse, and in that time we're losing babies to social care, which costs a lot of money, and I think that we need to really look at a fast track like IAP services, that when they're pregnant, they're actually fast-tracked for assessment and support. Why can't we do that for these women that come into these who are complex? So that's where I'm coming from, that point.
Yeah. It's really interesting points. And yeah, I mean, the assessment process for all of these services, I guess, is
not fit for purpose.
Yeah, I mean, well, one thing is, what are the assessments trying to achieve? And there is clearly part of some assessment processes is about rationing resources.
Yeah.
It is about trying to identify people who we think are over some threshold, and that we should invest resources in them rather than, which is not necessarily about trying to understand the complete needs of that individual. And how do we separate out this kind of how we manage limited resources from being able to carry out kind of holistic assessment processes. I think that's really challenging. And that just,
Can I
personal level, having a child going through the autism pathway, it's like 2 years down the line.
So when they're pregnant, it's even more difficult.
Yeah,
and when they are going through social care support, the threat of them losing their babies to social care is so then you disengage. So for me, it's how these assessments should be more individualized, and actually we should be following the same assessment in different, it's different in different areas for me.
And it's not necessarily,
necessarily
limiting access to resources, not necessarily cost effective either, because as you say, if children are only being taken into care that could have been prevented,
yes,
then that's potentially costing a lot more.
I think if I could just say, I think it's very intergenerational as well. These families with complex needs, it's often started when they were in utero, so we do need to invest in that. I mean, there's studies of epigenetics now where, they're showing that there's been perinatal mental health or other issues going on, domestic violence, whatever, really complex needs while the mum's been pregnant. The damage is already done, if you like, and then that child will go on to have that. So by investing at a very early stage, i.e. when the mum is pregnant, and getting her the support she needs. So for me, as a continuity midwife, mine was about accessibility of services as well, and ensuring the joined up services so that everything was all utilising the community services such as the hub. So when this person goes to an appointment, they can have access to all different services all under one roof as well. And I know that is already taking place in some areas, but there needs to be a lot more of that.
Yeah. I mean, one of the sort of priority areas that was sort of identified in this work is around the mental health of young women in particular. Because I mean, you see, looking at the data, and it's incredible how much that's only the mental health problems that are known about, how much that increases in the teenage years amongst young girls in particular. I think it's about 7 out of 100 teenage girls are already in contact with services for mental health problems. And potentially that's the point that you could prevent that intergeneration of issues. Great, so I'll now open up to the floor for any questions from anyone for our panel.
I do many things. I've got eyes in the back of my head. Thank you, panel. It's really, really fascinating, set of statements by you all. Really interesting information. And I went back to one of your slides, really, where I suppose my point is about governance. So I want to sound a bit negative, but I've got a bit of hope at the end. And I'd appreciate some comments back on it. I should say my name is Jerry Allen. Sorry, I'm a public advisor. And for my sins, I was formerly a Sure Start program manager. So my perspective is, I think commissioning, particularly by local authorities, is not driven by need. It's driven by the need to manage the resources and share out those resources, and yes, in an ever shrinking way. And then governance is often about the need to hold on to those ever shrinking resources, which is why you end up with the spectre of third sector, for example, really getting nothing off the table when it comes to those things. So I suppose comments back on that would be useful. I'm a bit more optimistic though, because I think the public advisor model through the ARC is actually a really innovative way forward, because very often you don't get meaningful engagement around the table in those governance structures. But my experience of public advisors today, there's lots of people in the room with public advisors, is that really is meaningful. And actually those people can get involved, for example, in funding bids, grant bids, and begin to make some difference. So those are my observations, really. If there's any comments back on that?
Yeah, I think a lot of the sort of unhealthy, or some of the way sort of organisations struggle with this is related to the sort of the limitation on resources and how that gets then kind of managed.
I've got my microphone, thank you. That was really interesting, because I jotted down that commissioners, I want to be answering the question, actually addressing the needs, like are they actually answering the right question? Have people asked the right question? And I would love everything that is commissioned to be looked at through the lens of the inverse care law and the lens of those with lived experience, and not bringing commissioners back down to normality, but just running things past people who aren't in the room, just who haven't been cited on this, haven't lived with this, aren't passionate and enthusiastic, and just bring those things back. I really wanted to say about housing, because I didn't quite get a chance to say about how could the ARC support this. And one of the things about housing, because I could, one of my big passions is about child death. And I would urge everybody here in the room and online to read the NCMD, the National Child Mortality Database. If you Google NCMD, there is a child deprivation report. It is only 35 pages and there's lots of pictures, but it's very hard hitting. And certainly as a clinician, death is quite a stark endpoint. And, that's it. And I'm going to quote, 1/5 of all child deaths could be avoided if children living in the most deprived areas had the same mortality than those in the least. And this is across all causes of child death except cancer, across all ages. And I can tell you now, looking back at research, that if you tell me the postcode of a pregnant woman, the risk of her unborn child dying, and I can also probably argue with evidence that is the same if I look 100, 200 years ago in the same parts of Liverpool. That has not changed. It's the absolute crucial aspect of housing, which brings me back to legal literacy and housing rights and employment rights and domestic abuse law, all sorts of things there. So I think there's something about child death, and that's something that the ICSs are probably big enough as an area to really drill down and use child mortality data in a qualitative and quantitative way to look at that. Housing, and also I think I'd be really interested in some research around moral distress and moral injury of staff dealing with this, because I think we know where these families are, we know them, and there is no simple answer. And we are living with the uncertainty and supporting those families to be as strong in their relationships as they can be. But it's not, you give them a course of antibiotic goodness and then that's it, it's all sorted. It's not going to be sorted. There is no end point. And we're kidding ourselves if we think we'll come up with an action plan and that family will no longer have complex needs. And I think there needs to be some sort of recognition of the impact on professionals dealing with families in the spectre of absolute finite resources and decreasing staff and increasing workloads.
Yeah, all good points. So There's so many things in there I can't think what. But yes, I mean, there are huge inequalities, and there's no way, that they're going to address issues by, the services that are out there are going to be picking up the consequences of the social conditions that people are living in, and that causes huge pressure on the people working in this, as well as the households themselves. Another question.
Thank you so much for your presentation and to the panel. My name is Dr. Sakeju. I'm one of the public advisors. I was listening to all the 4 areas about how we can support the system. Right, because at the moment it's the commissioning as well. I would like to know how the commissioning can be done together with the ICS being implemented next month. Correct this, because at the moment mental health is commissioned separately and midwifery separately. So if a woman is start baby and there's domestic violence, social worker, as the lady said, critical noticer, the police will be involved. So is it not about looking at the commissioning of the services as well? The gentleman mentioned about sure start. It was a brilliant idea. I was a midwife then. The sure starts were within the community. I can't believe how the government stopped that, because you can see the baby growing, the baby stop and go there, and the mothers know one another. And everything, you can walk, the social worker will be there. Now you don't even have social worker in the maternity services probably nowadays. So it's how we can make sure commissioning the service, looking at the family as a whole unit. You understand? Not just that's the child, that's the mother, that's the father. It's a complete unit. Thank you.
Yeah, I think those are all really important things. And yeah, I mean, I doubt the formation of the integrated care system is going to solve all problems. We've had several sort of reorganizations in the past, but I think organizations getting together and thinking about how to commission services jointly is something which I think is potentially getting better. Let's move on to another question. Else? Do you, Mark?
All I'm going to do is throw in the fact we've had Marmot teams doing reviews on health inequalities both in the north of our patch and the south of our patch, and we need to find a way to knit that in a way that doesn't give them all the power but allows us to build on some of their knowledge and expertise and weave that into innovative and somebody talked about the sum of the parts ways of not only reorganizing commissioning and services, but also weaving the evaluation of that into part of the day job for the practitioners, not that people come in from somewhere else, do some research and go away, but to make it part of that development cycle. That's a challenge for the ARC, I think.
Yeah, I mean, I think we've known for a long time what the needs are and what the inequalities are, but it's creating that change that's the issue.
Hi, I'm Jenny. I'm a research associate at UCLan, but I'm also completing my PhD at Edge Hill. And I think 2 points that you sort of raised really resonated with me. So the first one about sort of dads not being as involved in the services. I was at a launch, I think 2 weeks ago, for the reproductive trauma service, and they've worked really closely with DadsNet to try and get more dads involved in seeking support. And I think that is going to be something that would be really useful. And if that could be sort of wider, that would be great. And then the sort of second point was where you were talking about the transition from seeking support for a child to a teenager to an adult. And as part of my PhD, I've talked to lots of families of autistic children, and a lot of my research is around how to get, extended family more involved in supporting the child and parents getting them to seek support themselves, and they're relying on, you know, support for parents. And I just wanted to know, like, what thoughts do you have on how to better manage the transition for these families, sort of going from the child services to the adult services?
Sorry, I'm going to say something. I just like to say, I totally agree with you. I think engaging dads is difficult. It's not an easy job. I think what Michael's raised with the maternal mental health service, this is how we were commissioned. We are starting a dad's pad. I don't know if you heard of dad's pad. It's basically trying to engage dads in the service, but we're not commissioned to actually provide that therapeutic work. And that's something that we need to highlight as a service to our commissioners going forward, that there's this need there. I would say that families are really complex. They know when to hide as well. And I think we've got to work differently. Sure Start definitely worked. Originally, I was a Sure Start midwife many, Dorcas knows this, many years ago. And it did work, but we still weren't achieving what we should have achieved. The model was great, but we need to change now. These families know how to avoid services. But I think that services hasn't changed too much. It's been like a tick box exercise, really, to provide data, to provide research, and we've got to work a bit differently, really.
At the risk of sounding like I'm kind of in love with the Sure Start model, but I do think there are a number of things about it that were quite interesting. Possibly it was the greatest innovation of the new Labour government, but that's for another time. So in order to set up a Sure Start local programme, you had to do a community consultation. So you had to work with the local community, and there were 27, 28 Sure Start local programmes in Liverpool. So they were relatively contained. I was in the one in West Everton and Breckfield, and you had to ask your community, what do you want? And I think one of the problems that we've got here is, how are we managing a limited resource for them? And actually we're starting in the wrong place there. It's about, having that conversation and sharing that information and resource with local communities. So that's one thing I was going to say. Just in terms of talking about public advisors, one of the things that we had in West Everton Breckfield was parent advisors or community parents. So suddenly, actually, the community become a resource rather than only being a demand. But you only get that when you've engaged with them meaningfully. So we can't expect people to suddenly kind of pick up, provide extended care, extended family care when they've been subject to, care plans and so on. We have to engage with them at the outset.
Yeah, I think that's one of the things. One of the potential solutions, or an old solution, really, is having something that is based within those communities that persists over time and can enable those relationships to be built up, so that we can sort of inverse that relationship between services and the community, and move the people in a place to be influencing those decisions. I'm just going to check if there are any questions online from anyone. I think we will be able to hear you if you speak, or anything you want to put in the chat. And whilst that's happening, I'll just go to one more question, and then we may need to wrap up.
Thank you. So Rachel Anderson from the University of Liverpool, working with a number of people on the panel. So yeah, you mentioned that perhaps a lot of what the families are experiencing is intergenerational poverty, and the need to sort of look at the needs of the whole family and how difficult that is. But one thing is that it often seems to happen at a late stage when families are at crisis point. And Carmel, you said that the beauty of coming in at the stage of maternity services is that you have a chance to come in and offer support at the start of a life. But the trouble is, that there are still multiple things happening in the family and that have been passed on, either traumas or mental health difficulties, and we know them very well. So I suppose just to think about solutions, you've talked a lot about Sure Start. Do we know what the family hubs are going to look like, and could they be part of this sort of looking at things differently in a inclusive, universal way? So I wondered if anyone in the room can speak to that.
Yep. Does anybody want to talk about family hubs?
I would say that family hubs are, can we call them the old Sure Start? Because are we reinventing the wheel? I think we need, within that family hub, we need a midwife, we need a health visitor, we need a family therapist, we need a social worker working with these complex families, and I think that's really important. We need services in there. So yes, I agree, I totally agree with you, Rachel, and I hope the family hubs become the old Sure Start model. I hope that's what's going to happen. And for me, I'd just say, regarding Rachel's point about pregnancy, yes, it's really, really important. However, we're scoping across Cheshire and Merseyside at the moment with regards to learning difficulty services. And what has been raised is that women are only, when they are at crisis point, do LD services know about these women. So when the baby's actually being removed or going through an assessment, that is the time that learning difficulty services across Medicare know about these women. So for me, that is, we're failing already. I think, because that actually disengages those women from that assessment, because once social care become involved, it becomes then that the baby is on a plan, being removed, and they totally disengage. So I think we've got such a lot of work to do with.
And that sounds like a really practical change that could happen, and it's something actually that we could specifically look at in this bit of work.
It's all right. So it's tricky because when I've tried to introduce mums that I'm working with that have a degree of learning difficulty to the learning disability services of Merseycare, they say no, she's not learning disabled enough. But then from a social care point of view, the care is not good enough. So we've got an issue in terms of thresholds there. I would also raise a point in terms of research. The original Sure Start local programme was seen to fail. And I think one of the problems there was the evaluation done by Birkbeck College was really struggled with the diversity of provision across Sure Start local programmes. But of course they were meant to be diverse because they were meant to be responsive to local communities. So one of the research issues for me is how do you measure kind of outcomes and success when you've got very diverse kind of programmes going on. I'm not sure that the family hubs are going to be completely the same as the Sure Start local programme because there isn't the money behind them. But actually there's an opportunity for services to reorganise themselves around those hubs and, as you say, have people in them rather than having withdrawing your professionals into silos. And without, I think all services have done it. They've kind of retreated into their own little kind of professional enclave. And to get to them, you have to kind of go through an anonymous phone system. And that does not build relationships. So we need to be out there in community locations, working alongside each other.
That's the thing is, how we can make those community hubs or kind of community-led than sort of service-led.
For family hubs, but the government made local authorities compete with 6 programmes. So actually, I think the point you made about Sure Start was whilst they were right on a national basis, better start always prove the point that if you invest properly and government recognise that by investing in those areas, then that would be hopefully the model for the future. It's a huge investment. But pioneers want to Blackpool.
Can I just say one thing, just on a midwifery point of view, and Joe will highlight this, continuity of care is actually is really highlighting the work that midwives are doing nationally. We do have some continuity of care teams within Cheshire and Merseyside, and the data show the really good outcomes and the engagement from really complex families. So I think nationally we've had a problem with continuity of care, but now it's actually because we didn't have the midwives, the staff to actually provide it, but now it's starting to turn into,
and that's kind of identifying the things that are working and doing more of that as part of that. Rani, and then I've just
thought of one tiny thing. So I was asked to speak to the Maternity Disparities Task Force about preconception care and what primary care could do for this. And one of the things that helped was thinking constructively about who we are aiming things at. So for example, for preconception care, are you giving advice that is for everybody? So whatever your gender, whatever your biology, we're sort of advising you not to smoke and don't drink too much. Are you people planning a pregnancy? And we're not at all saying go to your GP, because that's not going to happen. So a lot of preconception care is going to be opportunistic. So that's where the NHS mantra of sort of every contact counts is really important. Second and subsequent pregnancies, they're the people we know about because we already have contact with them. And they're the thing. And then a subsection of those would be targeted. So, for example, I would say we could perhaps do some research in the targeted group. So, for example, care experience women who have, what kind of experience have they had of parenting? They're a really good group to get in touch with. Women in the secure estate who come with all that trauma, the vast majority have got immense trauma, and they're coming out, and how do we support them for their parenting needs for the future? So I think we could narrow it down a bit, because if you get things right for the women, you'll get things right for the babies and support them before.
That's exactly what I was thinking, that having moving back a generation, thinking of the next generation, I suppose is one way of thinking. Okay, well, we've run out of time. Paul, does somebody had anything else that you wanted to say to us?
Just one quick comment, is just about touch points. Obviously, you mentioned maternity, but all kids go through to school, and I just don't think we maybe engage with the school enough, or give the schools support to engage and then signpost to other places. So, that jump from, going into school in the first place, but then from infants into juniors, and then juniors into senior school is a massive jump for some of these children, and for the families, that because they'll see more problems as they move through that. And I don't think we utilise those kind of touch points or stages in a child's life enough.
Can I just highlight that? Sorry, very quickly.
It's your lunch.
If you look at the children under 5 across Liverpool, the social inclusion of under 5s is one of the highest in the country, and a lot of it's to do with complex families, domestic violence, what's going on at home. And I think what Paul's doing is absolutely fabulous. The link into that, the under 5s, and that would be really, really good.
Yeah, really important. And so, thank you, everyone. And I would like to thank the panel.